I now am going to welcome back our speaker, Dr. Anna Maria South. Again, is an assistant professor in the College of Medicine, Division of Hospital Medicine, and an attending physician on the Addiction Consult and Education Service, or ACES, at UK. She graduated from Ohio State University with a Bachelor of Science in Biology and received her MD from Boonshaw School of Medicine in Dayton. She completed a residency in internal medicine at UK, then joined the Division of Hospital Medicine as a hospitalist. She has been the recipient of numerous medical student teaching awards, as well as awards from her division for patient advocacy and excellence in patient care. She also serves as one of the health equity and advocacy thread leaders for the College of Medicine. And in 2022, Dr. South was selected as UK's Bell Addiction Medicine Scholar, a position that was renewed in 2023. So again, welcome back, Dr. Anna Maria South.
Thank you for having me back for the Q&A session. I don't have any relevant financial disclosures, no changes from last week here. And in the first few minutes, we're going to go over the highlights from last week's presentation to kind of remind everybody what we talked about. And then we'll go over the questions that were sent in. And then I will open it up for more questions. I will try to monitor the chat as well, but feel free to put stuff in here. I just want to remind everybody the practice gaps, why it's important for us to learn about this. Patients with opioid use disorder do have a disability that's protected by the Americans with Disabilities Act that was released officially in a statement by the Department of Justice in April 2022. So fairly new information, which means that there is a lot of patients and also patient care providers, physicians, social workers, peer support specialists that do not know that yet and do not know how to file a case for a violation of of the ADA. And so the whole goal of the series was to explain how to advocate for increased access for medication for opioid use disorder so that we can decrease health inequities and resulting health disparities by using the ADA. So the guiding principles of the entire series is we know that opioid use disorder is a chronic medical disease. We do know that the ADA in general is a civil rights that gives protections to individuals with disabilities. And we do know that because opioid use disorder substantially limits one or more major life activities, it is considered a disability under the ADA that is protected. And therefore, if you discriminate against somebody based on the fact that they are on MOUD, it is a violation of the ADA. And we need to advocate for our patients to ensure that all public entities, so any like hospital, jail, SNF, anything really that serves the public is in compliance with the ADA and does not discriminate against our patients or us for being on MOUD. So as a reminder, in case somebody forgot, the ADA is a civil rights law that came into effect in 1990, and it prohibits discrimination against people with disabilities in everyday activities, and that includes working, but it also includes access to healthcare. And this is to be followed by government institutions and public entities. And so that means even people that are privately funded, like some nursing homes that have private funding, or some jails or prisons that are under private funding but serve the public, they still fall under the ADA based on different titles of the law. So the other thing that we know is that medication for opioid use disorder is mortality reducing. Somebody that has an untreated opioid use disorder has a mortality that's 6 times higher than the general population. However, if we have this patient engaged in care and on mortality reducing medication, so that's methadone or buprenorphine, which is also known under the brand name of Suboxone, that mortality is reduced to about 1.8 times the general population. So access to medication for our patients is really, really critical. As I've mentioned, the Department of Justice released this in April of 2022, stating that patients with opioid use disorder do have a disability, and the ADA protects people with opioid use disorder who are taking medication, such as MOUD. So that incorporates Naltrexone, which is extended release form, is known as Vivitrol. Then buprenorphine, which a lot of people know under the formulation of Suboxone or also Subutex. And then the extended release injectable formulation Sublocade. And there's other formulations on the market. And then methadone. Um, it also includes people with opioid use disorder who participate in a substance use treatment program, so like a residential program, things like that. And it protects people with a past medical history of opioid use disorder who no longer use illegal substances. And just to clarify, that also means if somebody has chronic back pain or any other medical condition and is prescribed oxycodone or another full agonist or opioid for treatment of pain and is taking that as prescribed by their physician, it's also illegal to discriminate against that person based on the ADA. And the ADA does not protect illicit substance use. However, the exception to that is you cannot withhold medical care from somebody because they're using illicit substances. And I will come back to that in one of the questions that was sent in. This is where we can find out more information about the ADA and where we can file cases on how to report a violation of the ADA. So ada.gov is the general website that has information on there, including about opioid use disorder, but also other disabilities, medical conditions that are covered by the ADA. If you do want to report a case, it takes you to civilrights.justice.gov. That's where you can report a violation. You can also contact your assistant U.S. attorney, and then there's nonprofit organizations such as the Legal Action Center, the American Civil Liberties Union, or then here in Kentucky, we also have Vital Strategies who are working on this. And then, of course, there's always the option to have a private attorney if the patient wants it. All the other options are free of charge for patients, so something to take into consideration. And then how to file a potential ADA violation. You observe that something happened to a patient that has opioid use disorder, and then just making sure that this is actually based on a policy, not an individualized medical assessment. So, maybe talking to the provider and saying, what is the reason why this patient can't continue Suboxone? And then if they say something like, well, our facility doesn't have Suboxone on formulary, or we never take patients on Suboxone or something like that, then that is a policy, a blanket policy that is not based on an individualized medical assessment. I always make sure that I document the details of the conversation, either writing it down in a Word document by hand or in an email, so that I can have them available when I submit a case. And then you just submit a case on the websites that I mentioned before or via email to the Assistant U.S. Attorney of your district. So pretty straightforward. And then these were the cases that we discussed that were kind of landmark cases nationally and on a state level as far as ADA violations go. So the first case where the ADA was enforced because somebody was being discriminated against for being on buprenorphine was a case in Massachusetts where a patient was denied evaluation for a life-saving lung transplant and then had to move to a different state to be evaluated there. And that case was settled by saying that the hospital cannot screen out an individual or group of individuals, which in this case was patients with opioid use disorder, from receiving healthcare services as a blanket policy. So the hospital is obligated to perform an individualized medical assessment for this patient. I highlighted the first case that I'm aware of that we had in the state of Kentucky. This was against a practice at King's Daughters Medical Center, and a patient that was seeking treatment for a different psychiatric condition, not opioid use disorder, was declined to establish care there after they reviewed her Casper and saw that she was on buprenorphine. And that settlement said that providers cannot refuse to provide care to patients due to being on MOUD or demand for patients to be off MOUD before they establish care with them. So you have to evaluate a patient and see if they're appropriate for your practice. I also highlighted a few cases that were related to incarceration. So the first one was Pesca versus Kuppinger. That was also in Massachusetts. This was somebody who was getting incarcerated that was on methadone. And that case said that this patient was allowed to continue methadone while incarcerated. And after that, there was multiple cases, including here in Kentucky, that said that withholding MOUD upon incarceration as a blanket policy is a violation of the ADA. And I also highlighted with that the United States and Massachusetts trial court. And that was a drug court that mandated for every patient to be on Vivitrol to participate in it or to be on parole. So that was not based on an individualized assessment, but everybody, even if they weren't on MOUD or if they were on buprenorphine or methadone, was mandated to switch to Vivitrol. And that was ruled to be a violation of the ADA. And in addition, it was said that the drug court could not mandate a specific medication, but that was based on the expertise of a medical provider instead. So that was a summary, the whirlwind highlights of last week's presentation. I'll pause here for a second to take questions, and then we can move on to the questions you all submitted. All right. So the first question that was submitted is it considered an ADA violation if pain clinics discover that a patient is on MOUD upon a CASPER review and refuse to schedule them? And I actually had feedback session with one of the lawyers that we work with to specifically discuss that question. So I wanted to make sure that I gave the correct answer. And the answer is yes, that is an ADA violation because it's a blanket policy. So I think similarly to the case that I discussed with King's Daughters is there's no individualized assessment performed. The only thing that's done is a CASPER is pulled and it's seen that this patient is on medication and then they're prohibited from scheduling them at the clinic. At least that's how I understood the question. So if that is the case, that is a violation of the ADA. So ideally, what would happen is that patient gets scheduled at the clinic and then gets assessed by a provider. And then that provider decides if it is medically appropriate for the patient to continue MOUD or to pursue other avenues of pain management in addition to being on MOUD, or what the best individualized treatment plan for that specific patient is. But being screened out from establishing care at a public entity is a violation of the ADA. I'm pausing to see if anyone has anything to chime in. I'm going to pause after each question. I see something in the chat. Yes, is it a violation of the ADA if a jail denies a person MOUD when incarcerated? That is absolutely an ADA violation. And I think out of all the case settlements we have, this is the one where we have the most settlements. We recently have one here in Fayette County against the Fayette County Detention Center. There's a lot of them out of Massachusetts. I think there's some out of New York and maybe Maryland as well. So there's a lot of settlements. Initially, they were all focused on individual plaintiffs, but then it got expanded to an entire group. So yes, absolutely, stopping MOUD upon incarceration is a violation of the ADA. And I think there's another question that was sent in that relates to that, so I will answer that too. The next question was, would a hospital as a public entity be in ADA violation if they do not have a high-risk pain medication management clinic? And I think this question is a little bit more complicated because it is not an ADA violation for a hospital to not provide a certain service based on what they have available in their resources. So for example, not every hospital in Kentucky has a liver transplant service available, right? But what they do instead is they refer their patients that need a liver transplant to the University of Kentucky where we can provide that service. And similarly is how I would think about pain management or high-risk pain medication management clinic. Um, Not every hospital, there's a lot of critical access hospitals where they just have an ER with maybe 5 beds or something. It's going to have the resources to provide that. But what they need to have available is the ability to refer somewhere, and they have to do that in a non-discriminatory fashion to, say, we will refer you no matter if you have a history of opioid use disorder or not. And if they don't do that, then they need to perform an individualized assessment to determine why the patient is not a candidate for a referral. Okay, something in the chat. Somebody asked me, how far can a case go back? That is a great question. I don't know the answer to that exactly as far as like what the statute of limitation is. But I will tell you, I have reported an ADA violation of a patient that was incarcerated several months prior to when I saw the patient. At that time was stable on MOUD. They discontinued the patient's Suboxone when the patient was incarcerated. And then the patient after release was not able to reestablish care with a Suboxone clinic or an addiction medicine provider, and had returned to use and then was hospitalized as a complication from their active use. And that's when I met them and I reported that case. So I think you can go back. As far as how many years, anything like that, I don't know the answer to that. That might be something we need to specifically discuss with attorney from the Legal Action Center, Vital Strategies, or the Assistant U.S. Attorney. And I would also say if there's ever a question on whether or not to report it, I would err on the side of reporting it, because even if it's outside of the time frame or if there's not enough information, the assistant U.S. attorney does keep track of all of these cases and reports. So even if it's whatever you're reporting is not something that they can act upon for whatever reason, they're still going to collect it. And if there's multiple reports about that specific institution, they can gather it all together to form a bigger picture. Okay, then the next question was very nuanced, I thought. Would a blanket policy for an organization to offer Sublocade only, but not sublingual buprenorphine, be considered an ADA violation? I think this question is very complicated. I am not aware of any case settlements that specifically address that. So Sublocade is the extended release formulation of buprenorphine. And I think every patient needs an individualized treatment plan, and there's some people that will feel like the sublingual product at that moment is fitting better into their life than the extended release for whatever reason. But of course, the extended release too comes with a lot of other barriers sometimes. So it has to be delivered from a specialty pharmacy. It has to be kept refrigerated before administration. Some insurances might not pay for it. And if you look at the data between the two of them, there isn't really much like any difference as far as I'm aware, as far as mortality reducing goes. So what we want to focus on, or currently are focusing on, is really increasing the access to mortality reducing medication for our patients with opioid use disorder. And ideally, every patient gets an assessment from a physician to see if, the sublingual product is more ideal in this patient's case compared to the extended release. I'm not aware of any facilities that only allow extended release as compared to sublingual. So maybe if the person that asked the question could specify on that further. But I think, we want to focus on individualized assessments. It doesn't sound like there's an individualized assessment taking place in this case if it's a blanket policy. However, there isn't really any difference in mortality reducing benefit of this for the patient. So I will leave it at that. Is the person who asked that question here and maybe wants to clarify further? Any other questions on this? If not, I'll move on, but you guys can feel free to interrupt at any time, unmute yourself or put something in the chat. The next question that was submitted was, is it correct that a detention center that allows buprenorphine but not methadone in jail would also be an ADA violation? And the answer for that is yes, absolutely. And I think, if we think about it, there's a reason why a patient is on methadone as opposed to buprenorphine, right? And that reason and decision was made when they were assessed by a medical provider and they developed a treatment plan for that patient. And in addition, if somebody is on methadone, they might be really stable from their opioid use disorder perspective as far as medical complications, everything goes. So, to then destabilize this patient while they're incarcerated would absolutely be a discrimination by stopping their methadone. And in addition, most of you probably know it's fairly complicated to switch from methadone to buprenorphine. Methadone is a full agonist of the mu receptor. And if somebody's on a high dose methadone, that has a long half-life. It's going to take a lot of time for this to clear the patient's system. And they're going to go through withdrawal that needs to be managed at that time, usually with a medical provider. And then to initiate buprenorphine, usually what we would do is called microdosing. So we would give small baby doses of the buprenorphine, which is a partial agonist, to slowly transition somebody to methadone, or have a significant washout period where they're not on methadone before, where they might have cravings and withdrawal before starting buprenorphine. Because if you just give somebody that's on methadone buprenorphine, they're going to go into what's called precipitated withdrawal, which is, withdrawal all at once, awful. They go from feeling fine or normal to having severe, muscle aches, joint aches, diarrhea, agitation, nausea, vomiting, just the worst feeling. So if a methadone cannot provide, if a jail or prison cannot provide methadone, that is a violation of the ADA. The methadone regulations are currently under review, as far as I'm aware, and they were taking comments from the public, and some of the comments that the public put in was to say that detention centers should be considered closed systems like hospitals are, so that pharmacies there can dispense it. So hopefully that's something that'll come through and make it a lot easier for the detention centers to dispense methadone. Otherwise, they're going to have to partner with a methadone clinic and figure out how to get the methadone from the clinic into the detention center. Or people that are incarcerated get transferred to different facilities all the time. I know, for example, there is the Federal Detention Center here in Lexington is one of the ones that doesn't offer dialysis, at least last time I checked. So if you have a federal prisoner that's there that is on dialysis, that patient then gets transferred to a different prison. And I see that in my hospitalist experience all the time. So if we're doing that for end-stage renal disease, the same could be applied to opioid use disorder. That was a long answer. So I'll pause for a second to see if there's questions about methadone in carceral settings. Based on your experience, what is the best approach if a person feels that a facility in which they receive care committed an ADA violation? Should they speak to the facility first, or should the first step be to report it on the civil rights website? So this is a nuanced question, and I think it depends on the situation. I do, want to remind everybody that if you report something on the website or reach out to the assistant U.S. attorney, a lot of time it takes weeks or months or even years until a settlement is reached. So if you are the patient that is being discriminated against, that timeline might just not work for you. We do know that the assistant U.S. attorney can reach out to facilities and help to try to make sure an individual patient is receiving the care they need while everything else is being figured out and investigated. So that is always an option. However, these things do take time. I also do understand, though, that sometimes there's a power dynamics difference, and it might be challenging to speak up in a situation where you feel like you're being discriminated against because you worry that it opens you up for further discrimination. You are protected under the ADA if you report a violation, but I understand that it can be really hard. So my answer is ideally both, so that you can, number one, advocate for yourself in the facility, and then number two, also on a broader basis, ensure that that facility going forward is compliant with the ADA for other patients or clients in the future. However, I do understand that it's challenging, and I will admit, for me as a physician, reporting it the very first time was hard. It was challenging, and I didn't know if I was doing everything right. So it was nice to speak to a lawyer that has experience in this and kind of could answer my questions and back me up on things that I was not familiar with, that are not my area of expertise. Um, so yeah, I can understand why sometimes it's really hard to speak up and advocate for yourself, but I will empower you that that is the best way to get change. And as we heard in our in the presentation last week, there is a person here in recovery that was able to report against the clinic at King's Daughters, and then the settlement was reached. So that's really powerful, I think, going forward, to know that we as patients also have that ability. It was mentioned in the last session that facilities are required to post updated policies regarding ADA regulations in their reception area on the website and provide education to the staff. Who monitors that this requirement has been implemented? Is this requirement for all facilities or just ones that had violations? Does this also apply for jails? So 3 questions in one. The first question, who monitors it? That's the Assistant U.S. Attorney's Office. So a lot of times in the settlements, what comes up is like an agreement that they need to ensure ADA compliance, and they need to come up with a plan of how they're going to ensure ADA compliance. They submit that to the Assistant U.S. Attorney, who then has a team that reviews that under the Department of Justice to make sure it's in compliance with the ADA, and they monitor enforcement. And once a settlement has reached, if you go to that clinic or jail or hospital or nursing home, whatever, and you feel like the settlement is not upheld, then you can always reach out to the Assistant U.S. Attorney and make them aware. Is this required for all facilities or just ones that had violations? So in general, yes, every facility needs to be in compliance with the ADA, and ideally would state that. But usually if it's in the settlement for the ones that had violations, they are the ones that have to do the specific training and everything. And then does this apply for jails? So we know from the presentation last week that unfortunately not all jails and prisons are in compliance with the ADA, and that the most common practice still is that they discontinue medication for opioid use disorder upon incarceration, which is a clear ADA violation. But those need to be reported so that the Assistant U.S. Attorney can follow up on it. So I don't think that most jails or prisons right now have flyers up in their reception area saying we're in compliance with the ADA. So ideally, yes, but that is not what's currently happening. Okay. In the case of Fayette County Detention Center ADA's violation, it seems the violation was only regarding withholding medication for a patient with OUD already on MOUD prior to incarceration. Why is it not a violation to refuse to initiate MOUD with incarcerated individuals with opioid use disorder? So I'm going to answer that question first, and then I'll go to the second part of this slide. Yes, so that is how this settlement is framed. And we've actually met with the attorneys from Vital Strategies, and they said it depends on how you interpret the ADA. And if you look at the ADA, as I said, it's the big law is we cannot discriminate against people with opioid use disorder on MOUD. Then the exception of that is illicit substance use is not protected under the ADA. And then the exception to the exception is that people should not be withheld medical services that they would be otherwise entitled to due to illicit substance use. And this is how you apply the ADA to people who are being incarcerated. that have an active opioid use disorder that are not on MOUD, because everybody that has an opioid use disorder can be evaluated for opioid use disorder and initiation of MOUD. And withholding that is withholding medical services that a patient is otherwise entitled to. And so therefore it would still be a violation of the ADA under that interpretation. However, I think the cesspool, so to speak, of violations is so deep at this point, there is no case settlement that says that. And I think that means, number one, we need to report more, but also there's so much work to be done that right now, maybe some of the official channels are more focused of continuation of MOUD, because otherwise it's so many people, and it's really a lot of people that would benefit from it. But as I mentioned in my presentation last week, those are the people that are at highest risk for dying from an overdose after release from incarceration. So this is really people that are at a very vulnerable state in their life that we have this great opportunity to reach and talk about mortality reducing medication. And my personal thought on this is looking at these states that actually have initiated screening processes upon incarceration, with then offering all three forms of MOUD, continuing it while people are incarcerated, and close linkage to care after release from incarceration. Usually that comes either through an executive order or some sort of legislative action that demands that. And that's probably the best way to get it done on a statewide or nationwide level, just because otherwise, I mean, as I said, we have so many county jails and prisons. To get it enforced at every single one under an ADA violation, it's going to take a lot of time, and that's time while people are dying. And then also to clarify, if a settlement is made for one county jail, is it correct the decision only applies to this particular county jail, while other jails in the state can continue with similar ADA violation practices? Whoever wrote this question is a kindred spirit, because this enrages me, right? Like, we have laws and we have protections, we have settlements, and yet there is still public entities that are violating the ADA. I think it's just change takes time. People might not be aware. They might have certain barriers that they see in their jail, like monitoring of controlled substances, worrying about risk for diversion, all of those things. And we really want to be good partners for them and help them with being in compliance with the ADA. So if you know of any jails or prisons that are struggling that want to work on that, I'm very happy to meet with anybody or assist with any potential programs that we can work on that. But yes, unfortunately, the settlement is specific to their specific public entity. So yeah, while other public entities also need to adhere to the ADA, they are not included in specific settlements. And when you look at the title of the settlement, it will name the public entity that it applies to. Okay, any questions? I just talked a lot. Okay, going forward. We hear about judges that oversee drug courts not allowing individuals to receive MOUD, or only allowing the person to be on Vivitrol. Is that an ADA violation? Yes, absolutely. We have the settlement out of the Massachusetts trial court that I cited in the beginning. There's two settlements against drug courts there and against probation office, like the Board of Probations. So yes, it is an ADA violation, and we should absolutely report that. We should absolutely make those judges aware, and they should be working with a provider that is has expertise in addiction medicine and can assess the individual clients or patients to determine which MOUD is the best for this patient. Okay, how much information is needed to successfully report a violation? For example, is it enough to state that on date you made a phone call to entity to attempt to schedule an appointment for medical service or specialty, but were informed by the person on the phone, which you may or may not have a name for, that this organization would not schedule you with them because you're an MOUD? Do you need something in writing regarding the policy or denial? So yes, that would absolutely be enough. I think usually I don't have anything in writing, and I usually just ask the person on the phone who I'm speaking to and what their title is so that I can include it. But even if you don't know it, still report it. You don't need anything in writing. If you have it, of course, submit it. I think the more information we submit, the easier it is for the Assistant U.S. Attorney to start an investigation. However, whatever you have submitted, and as I said before, even if what you submit is not enough for an investigation, if there's multiple submissions about the same public entity, that might, add up to be an investigation. And I think that was the last question that was submitted. So I do want to remind everybody that the work on this was supported by the Bell Addiction Medicine Scholar Program under the mentorship of Dr. Lofwall, and that the Addiction Consult Service at UK is grant funded, and Dr. Finucchi is in charge of that. And these are the sources I used, but I will go back so that we can ask more questions. And I'm happy to pull up a particular slide from the summary slide too, if somebody wants to see it again.
Thank you, Dr. South, for responding to questions that could be, again, very nuanced, but also very, I think, clear responses that maybe provided people a lot of feedback. I just want to remind people that if you do have a question that you don't want to personally ask, you can send a private chat, and we're happy to ask that on your behalf.
Absolutely.
I also see that you raised your hand, so I'll turn it over to you.
No, I just had, thank you, the great presentation again. What is the hesitancy, you think, in if someone knows there's a violation of another entity, why wouldn't that entity come forward and just correct it? Is it because there is not monetary settlements, or what is, based on your experience, why do you think one's not motivated to make those changes and make it right?
Yeah, that's a great question, because, and yeah, I think money is always an answer. I also think maybe people think they're not gonna get caught, right? Like, similarly to, if somebody steals a car and gets incarcerated, why doesn't that stop people from stealing cars, right? Sometimes punishment is not a strong deterrence if it doesn't apply to you. I think too, another thing is people might not be aware, right? Like, I don't know how many people are out there reading those settlements. I will tell you, my background is not at all legal. It's all medical, and it was a lot of work for me to read those and reread them and then discuss them with lawyers and figure out what they mean. So people might just not know or understand. And then I think there's always, the inertia of, we've always done it this way, why change our way? I think there's still a lot of stigma out in the community against MOUD, and people might not understand why it is so vital for people to be on medication that is so mortality reducing. And then just practical challenges, cost, who pays for medical care in jail or prisons, right? When people get incarcerated, their Medicaid lapses. And then having to pay for a provider to provide buprenorphine might be expensive, especially Sublocade costs like $1,800 per dose, I think. The sublingual product is cheaper, but then they might be concerned about diversion, things like that. And then also establishing ties with the community so that you can arrange good transition follow-up also is extra work. So just, yeah, I think stigma, lack of knowledge, the inertia of we've always done it that way. Those are big things I can think of off the top of my head.
Thank you. I had a question that was submitted directly to me. I'll read. Is there a time frame for when organizations must comply to the regulation? So, assuming jails would have to work to establish processes to ensure ADA compliance, is there a grace period since this announcement?
Yeah, that's a great question. So, in the settlement with Fayette County Detention Center, I think it's specified either 6 months or a year for them to come up with a plan on how they're going to be compliant with the ADA. And then that plan gets submitted to the team of the Assistant U.S. Attorney, and they review it to make sure that they agree that this is actually a good plan to be in compliance with the ADA, and then it goes back to them, and then they have, a certain time to enact that. So usually, to my understanding, that is not a set in stone time period, but each time period gets established in the settlements, and they do understand that it takes some time to do that. There's a question in the chat. Yeah, who is responsible for paying the bill for MOUD when the person is incarcerated? Would it be individual or the jail? Great question. The answer is Medicaid lapses when people get incarcerated, and then it is up to the facility to pay for their health care. If somebody gets hospitalized, I think after 24 hours in hospitalization, um, it gets picked back up by insurance, but in the outpatient setting, so in the jail, that would have to be picked up by the facility, which can be a barrier. I do think, though, that there's a lot of grant money out there that jails can apply for if they want to start a program like that.
So what ways do you think that we as individuals, but also just as a study, can try to make more people aware just in general of this? I know that, obviously we're getting aware from your presentation, and of course can share this presentation, but do you have other ideas of how we can just in generally educate more people that, about the ADA and what constitutes a violation?
Yeah, I think talking to people, right? So I notice this frequently in the hospital. People will be like, well, this patient wants to go to this rehab center, like, physical rehab, and can't go there because they're on Suboxone. And the case managers or social workers or the pharmacist and the primary team attending will just be like, okay, we'll look for a different one. And it's like, no, actually, let's talk about this. So just educating people as you see something. I usually tell my patients too, like, sometimes when I initiate people on medication, one of the questions I get from them is, I'm scared that I'm going to run into a certain situation and I'm going to be forced to stop my medication, and then to educate them that that is actually illegal. I've never met a patient that was aware of their protections under the ADA. As I said, it's still fairly new. So hopefully, as we get the word out, more people will be aware. I think, if you want to put up flyers in your clinics or different places to let people know, hey, this is where you can find more information about the ADA. I think the Legal Action Center has a few really, really good flyers that they're making, that they're getting out into the community. So I guess just spreading the word. And if you see something, even if you at this point, for whatever reason, can't report it or don't want to report it, empowering other people to report it and just letting people know what their rights are. There's something in the chat. Who would we contact to receive the grants? So I think there's some SAMHSA grants that you can apply for. That's who I would start with. I am curious, and if you guys don't feel comfortable sharing, you don't have to, but is there anyone here that has reported an ADA violation before that would like to maybe share how things went? Okay, no takers on that one. That's okay. It's like, fairly private question, so I understand.
I did think of one other question, doctors. If just for people that are more interested in this topic, I mean, about other cases, because I know you referenced a lot of the landmark cases, but if someone was interested in looking up other similar cases that apply to MOUD and the ADA, how would you say is the best way to go about trying to find information about those cases?
So how I did it is I Googled ADA and OUD settlements, very sophisticated. And then I actually found the Legal Action Center had a great page about different ADA settlements. And of course, I'm sure if I Google it now, I won't be able to find it that quick. I don't know if you're already on the web, but I thought that website was super helpful. Um, let me see if I can find it real quick in my email, because I emailed it to myself.
I might have found it. I'm going to put this link and then we can see if that's the same one that you found.
Yeah, let me click on it and see. Yes, this is exactly the one. I thought this document was super helpful because it had the specific settlements and then it explained what each of them meant and kind of took out some of the legal jargon. And then each of them too has like as a blue hyperlink, or a lot of them as a blue hyperlink where you can click and then access the actual settlement. And a lot of them, if you Google the name of the settlement, you can find it as well. So yes, I thought this document was super helpful. And we are working on getting more of this like published and getting it out there. So whenever we have more, I'm happy to share it with you guys, and then maybe you can send it out to the community.
That would be great. And we'd be happy to, of course, incorporate these resources. And I think I'm glad that these came up. Maybe the Legal Action Center resources, some of these resources we could include in along with the video of this presentation, just the links in our newsletter. And then if there are future items, we're happy to bring them back up in our newsletter and otherwise.
I was gonna say.
Chris, I would add here too, being the coordinator of the learning collaboratives, we have had 3 learning collaboratives that spoke specifically to writing grants and how to apply for grants. I'd be happy to share those videos with anyone that's interested in getting that information. And then in September, the HEAL team is planning to have a learning collaborative focused on the topic with the opioid abatement funding, how to apply for those, what strategies to use, best practices. And so we're going to have a whole session on that. So I just wanted to address that one person's questions about the grants and looking for information related to that.
That would be great. Yeah, that would be a great use of the settlements. Absolutely. And I just in the chat put a article that I wrote with Doctors Finucchi and Lawful in JAMA, where we discussed a little bit about the ADA and have some of the links specifically for MOUD in incarcerated settings. Health birds. Yes, absolutely. Great question. So the answer is you cannot refuse a patient based on being on MOUD. So yes, absolutely included. And the settlement against King's Daughters was specifically focused on that. That was somebody that was seeking treatment for PTSD. And I think there is public entities that based on that actually changed their policy about allowing buprenorphine, especially for inpatient psychiatry settings. So to go back to your question earlier about why it sometimes takes some time for people, there is some entities that are going with it. It's not everybody that's not doing it based on other settlements. Megan, did that answer the question?
Yes, ma'am, that was perfect. I had a similar experience whenever I personally I'm on buprenorphine myself, and I went to a local mental health clinic here that's pretty well known, and they were telling me that I had to get off my MOUD in order to get any kind of mental health medication. So I ended up going somewhere else because my recovery at the time, and it still is, very important. So
Yeah.
I've got a doctor now that's very supportive of my recovery and this the Suboxone that I'm on, and he still treats me to this day. So he's amazing. So, but I had that happen to me about maybe 2 years ago, and it was just very off-putting. So I'm just glad that this is starting to take place. And yeah, I really appreciate this learning about all this. So
thank you for sharing that experience. I'm sorry that you got discriminated against. That's awful. It shouldn't have happened. I'm glad that you still were able to get the care that you needed. I'm sorry that you had to go somewhere else, but it sounds like overall the story had a happy ending, but that is absolutely an ADA violation. And I think similar to the case against King's Daughters. So if you want to still report that, even if it's been 2 years, if that's still the policy there, I would absolutely encourage you to report it. To the assistant U.S. attorney. And if it's in Eastern Kentucky, that is Carrie Pond.
Hi, this is Shirley. The King's Daughters case was my case. It was the height of COVID and I was struggling real bad with PTSD. And basically I just started Googling. I knew it was wrong, but I didn't know anything about the ADA at that point. And I just started researching it. And then I found about the ADA and reached out to a couple people and they got me in touch with the federal government. And Carrie Pond was the one that she represents the United States, but she's the one that actually did what she did for King's Daughters. And it was a hospital policy, like it was all the way across the board that any provider they had, it was insane. If they were on MOUD, they couldn't be treated. If you had drug felonies, they didn't have to treat you. So it was just insane what she actually dug up, once they went in there. It is still an open investigation. My part of it is settled, but I think they have theirs open for them for 2 years. So if anybody that lives in the Ashland area that has been discriminated against, I can link you to Carrie Pond. I have her email address and her phone number as well. But we have to, we're our own voice, and it wasn't even about money for me. It was about how many people have committed suicide, how many people have overdosed and died because they couldn't get significant amount of help that they needed in that moment. And I know the mindset I was in, and I had waited 2 months for this appointment, 2 months for them to do what they did to me. They lied, said they called and I didn't answer, but that wasn't true at all. So anyway, make sure that you're educated and advocate for yourself and others coming behind you.
Wow. I'm so sorry again that happened to you. That's so wrong. And yeah, as you said, like withholding care from somebody because they've had a drug felony, that's a clear violation of the ADA too. So both of those cases that you described are clear violations. And I'm so glad that you spoke up and got in touch with Carrie and that a settlement was reached. And I'm glad you got the care you needed. But yes, I think everything you've said, I couldn't have said better myself. Like how many people are suffering or are dying because they're being discriminated against, and that shouldn't be the case. We know that medication for opioid use disorder is mortality reducing. It's so important for so many people's recovery, and we shouldn't force people to stop that medication just so that they can get another medical issue addressed. It's awful.